Um, yeah, we're very interested in healthcare reform and how that system is paid, because as you pointed out, the cost of our budget and what it means to the state is one thing, right? We know it's an enormous amount of general fund dollars, but the direction of the Medicaid program and how that leads, being that it's at least a 30% payer across the board, it really dictates the private healthcare market as well, along with the state employee retirement benefits. And so this is something that we all have to examine together. When you look at some items, and I was just going through some notes, we do Medicaid long-term cost projections and forecasting using evergreen economics. And so this is a report that we typically bring up to the legislature. And I was playing around because I'm a big nerd, and I found a report that we presented in January of 2020. So granted, the world has changed tremendously since that point in time. But in January of 2020, one of the items that we put forward in the report actually said that expected healthcare price inflation is going to be the primary driver of spending growth in the Medicaid system, accounting for 67% of growth between FY20 and FY2040. So when you think about that, the world has changed since then. How healthcare is delivered, the cost of care, how that has changed, and we don't yet know what the ramifications of this are going to be, with what individuals are going to be providing service, where they're going to be receiving at. This is still going to be something that is going to shake our healthcare system over the next couple of years until we see what the ramifications of COVID and other infectious diseases is going to be. So this is something we absolutely have to work together as we examine it. So I fully expect that that number is probably a little low. I think our healthcare cost inflation is going to go up, because one of the things we have seen from this is, due to the stress of the overall long-term pandemic, we have had a mass exodus from the healthcare workforce. Along with that, we've also had an arms race. And so that being said, that, you know, your traveling nurses and other groups that you're used to having on contract to supplement our Alaska healthcare system, the cost of those individuals has become untenable. And we, were able to step in as a state and help using some FEMA contracts to bring 475 healthcare providers to the state of Alaska. But this is something that is not going to be available after probably January or February. We have to, and we need to look at how do we actually improve recruiting into the state. And so this is something that Health and Social Services is having active conversations in with our universities. Are there incentive programs that we can help with to really drive this? Because, all of the healthcare providers have stepped up through the years in legislation like the SHARP program to do reimbursement towards, education costs. But there's a lot of items across the board that we really need to look at. So one of the things that we projected this a couple of years ago, just about the long-term cost of care and how we were going to do this. And one of the things that we came up with, and this was from the department side, is we need more time in the day for the commissioner's office. This is not my role. This is the deputy commissioner, health policy advisors, and other staff to actually have more bandwidth to tackle this issue, along with the other important issues. This is why one of the things we put forward from an innovation side is the proposed restructuring of health and social services into 2 departments. And so this is something we are still continuing to pursue. It's the governor's discretion whether or not he's going to reintroduce an executive order at the start of this coming legislative session, which would be in January. But we've continued our outreach. We've continued to let folks know. And really the idea behind this is alignment of services. We want our direct service providers for the state side, this is the API, Pioneer Home, OCS, DJJ, to be consolidated into a Department of Family and Community Services. And that would still be a department size of over 1,800 people, but they provide direct patient care 24 hours a day in facility or in community. And so they can do that and really focus on those critical issues along with the tribal liaison. And on the other side of the house, behavioral health, healthcare services, Division of Public Assistance, and Senior and Disability Services would join with public health under a department called the Department of Health. And with that, we look to really drive change in how our Alaskan system is done. And really what that is actually not pressure on providers. That is pressure on us as a state. Because one thing that COVID has really done has shown the vulnerability in our state systems. And so when we look at this, we see a lot of opportunity for growth. We see a lot of items and services that public health nursing or public health other groups will provide in community, but we're paying general fund dollars on that, where actually, in fact, some of those services could be reimbursed with Medicaid dollars if we actually had connections and relationships in place to make sure that happens. And so the more support we do that way, by relieving some of those general fund pressures, we can keep our public health system whole and possibly even reinvest towards other items. Because the thing that we've looked at, one thing that is very clear, regardless of the year that Evergreen Economics has presented the Medicaid report, is that we have got to find a way to add prevention to how we deliver healthcare. We have to find a way to incentivize it. We have to find a way to pay for it. And if that requires using our data teams at Public Health to implement this and use some innovation while we gather data through pilot projects, demonstration projects, and then present that information for possible waivers to CMS, this is an imperative that we have to do for the state of Alaska. Because along with the public health gaps, we have gaps across the board when it comes to a behavioral health system. Right now, we've got our 1115 waiver, which provides 23 new behavioral health services, covers a lot across the board, but we really just have those providers in community, emergency rooms in hospitals, or API. We don't have crisis now units stood up. We don't have intermediate care facilities for complex patients. And so we have a lot more investment that we really need to look at in order to identify the gap. Because that's one thing about Alaska with our hospital system. They really are community-based hospitals. And a lot of times individuals would be held there and taken care of, but it's inappropriate placement of care. It's wrong for the staff to have to do that because it's the wrong setting. It's wrong for the patient because they're not getting the environment they need to in a therapeutic setting. It's very stressful to be in an emergency room around the clock. There's a lot of noise, a lot of lights on all the time. And so we need to find better ways in order to provide that, whether that be investment using some of these upcoming possible infrastructure dollars that we're going to see from the federal government to put forward. How do we actually maybe operationalize that by building new facilities and then actually saying to a group, okay, the facility's built, don't worry about capital, now you have to go run it. Little things like that we're having conversations on. And then on the other side, we have been spending a lot of time with our direct service providers for our disabled and disability groups, as well as our seniors. And, they just brought up in conversation again yesterday that individuals they know for a fact they work with would be eligible for Medicaid waivers, but there is a gap in the system. And while our team runs around to try to make sure that as many people as possible are on this, particularly these vulnerable population, we have holes to where we are not maximizing this. And so when we look to and we say we need healthcare innovation from the state side and the reorganization can get there, this is for us to consolidate and allow a lot more managerial oversight and support to allow us to have our processes run better. And so that's a lot of stuff that we're really looking at. And I know it's very high level stuff, but those are some very critical aspects we're pursuing. So I'll throw it over to Deputy Commissioner Wall for some other kind of innovative things to address some questions.
Good morning. Thank you, Commissioner. I appreciate that. Wow, it's amazing how conversations come around again and again about different topics. I know historically over the years, we have as a department been moving towards something. It evolves, the conversation evolves, the budget evolves, the services evolve, and things change over time. And this last 18 months obviously has been a huge growth in change of both services, service delivery, funding of those services, and how we do healthcare as a whole. So I really want to look at that in context, because the exponential change within healthcare has been more rapid, in my opinion, in the last 18 months, and will continue to be so because of the pandemic than it has historically for some time. And so I think we need to be flexible and take a look at the opportunities that are provided because of that. I know there's a lot of impact and a lot of negative around COVID. I would say that there's also, with challenges come opportunity. And so I think that some opportunity has been provided not only through funding, but also more importantly, I think through, a relook at how we do healthcare I think in particular as a nation, but in particular as a state. How do we do healthcare? How do we pay for it? How do we make it sustainable? How do we make it accessible? Those are extremely important questions. And I'll probably focus just a little bit more on, Medicaid cost containment and reform this morning, just because that's kind of my lane. And I think that it's probably the way of the future. It's the only way that we're going to really get a hold of the cost of healthcare and how we kind of bend that curve. So it was an interesting, Mr. Townsend, I think earlier you mentioned, or one of the questions was, how are we going to react as a department to the PCG report? And I know, I kind of know why you worded it that way, and that historically a lot of reports have been just that. An agency will come in from the outside, kind of do a cold survey, not a whole lot of interaction. They'll present their findings, recommendations to the department, and they'll leave. In fact, that is not what happened this time. This roadmap that has been built with Public Consulting Group, in particular with Rich Albertoni, has been I would say a labor of love. That is, we started it, and then the pandemic hit, and so the conversation around cost containment obviously slowed down. And PCG kind of looked at how the rest of the nation was handling the pandemic and the impact of Medicaid. And it took us about a year to get back on that conversation and back on track. Not that we didn't do anything with it, but that the timing wasn't right to talk about cost containment and the change of services in the middle of that push of pandemic. We have been sitting, the reason why I bring it up that way is we have been sitting with Rich Albertoni and PCG now for 2 years. And he has met with our provider groups. He has met with our department. He's met with other departments. He's met with other states that have similar services or the similar lack of services that we do in their cost. And, we have together, not only the department and he, but our provider groups and he and the department have together put together that roadmap. There are a number of different items on it, and I'm kind of hoping you all have seen a draft of that or have an idea what that looks like. But as that final report is coming out, there are a number of items on it that really engage in a conversation that's more long-term, I think, than a lot of people in the state are used to talking about in healthcare. One of the restricting things that we have around healthcare is this annual conversation we have about budget. We're driven to a certain amount of money that's allocated for that particular year, and we are boxed in by that allocation and what we need to do with that year. The way many states are doing Medicaid in particular, because of the cost, is more of a multi-year appropriation that has multi-year goals built into it. And that has helped many states kind of get a hold of the rapid growth of the cost of healthcare. So one of the things that we're looking at, and I know it's not a new conversation, we've talked about it often, but over the years, but one of the things we're looking at is programs that have multi-year impact. And I'll just, use a couple of examples. One of the things that we're looking at more fully is just the idea of health homes. And health homes, of course, when you introduce them, they don't have immediate downward push on cost. The day a health home opens or people are put into a health home situation, you're not going to see a great reduction in their healthcare cost. But over time, that downward pressure, that consistent case management, that preventative care that the commissioner was talking about, that making sure that they get to their appointments on time, that their living arrangements are ones that are healthy. Those are things that are important for bringing down healthcare costs. So I don't want to take up all your time, but I would say that our focus has been on more than just what we're doing right now in the next 8 months. It's more a trajectory of where healthcare was headed as a whole over the course of the next coming years. That really has been our focus. And I would really like to thank, I know I see a number of them on the call here today, but I'd really like to thank our partners, everybody from, ASHNA, to ABHA, to, the tribal groups. We've been having a lot of conversations with them. APCA, almost every board and commission you can think of that has some impact in healthcare cost, we have engaged on in the last 18 months with this roadmap. So I know I've left some out, but I know there's a time for questions later, and I don't want to chew up all your time. So I will be quiet and hand it back over to the commissioner or Mr. Townsend.
Commissioner, are there additional things you'd like to say?
No, I think we just we leave it there, and I'm curious on the questions. See, we got a really good group of folks on this, and so there's a lot of people who've actually been thinking and talking about this for a long time. So I'd like to have some conversation, if that's all right.
Could you address the PCG report? We appreciate that. We also one of the broad questions was policy directives. Is there any sense of from the department's point of view about changes in federal policy that we should be anticipating, or is that still an open question for us?
Try to say this nicely. Yes, it's still an open question. Typically, by this point in time in an administration, you would have a pretty good idea of what the overall direction would be, and we have not seen it thus far. COVID has really, I think, derailed some things CMS wanted to try to do as we've been moving forward. So we haven't received that clear direction from our federal partners as much as we'd like. And, not to their fault, they've got other initiatives that they're trying to work on. So we've been humming along. Anytime that there have been kind of questions posed by the new federal administration, we've been really good and had some fantastic partnership with our tribal partners in particular about putting together really formal, very long, robust responses to CMS when they do these requests for additional information. So I'm just really grateful for that overall partnership, because we've got Alaskans standing together on this about the programs we have built and why we do things a certain way up here. As we always like to say, right, Alaska is unique.
Before I turn this over for questions that Juanetta will moderate, let me ask the very high level question, which I think is a fundamental challenge for Alaska policy. And Medicaid is one of the two largest programs for the state. And there's the saying, if you're going to deal with the state budget, you have to deal with Medicaid. But the reality is, for every dollar the state spends, we receive $2 to $3 federal dollars in match. So $100 million reduction in state spending for Medicaid would take $200 to $300 million out of the healthcare system, which obviously would affect the attractiveness of Alaska for providers. And I think that dynamic the legislature became very aware of that dynamic when faced with the proposal around ending optional dental services, which was proposed by the administration and then ultimately not implemented. So my question is, how do we deal with this fundamental problem that if we reduce state spending for our broad Medicaid programs, we will remove very substantial amounts of money from the Alaska healthcare system and in particular from the tribal system?
Yeah, I appreciate that. It is an interesting question because Medicaid drives the bus, so to speak, when it comes to the overall budget. One thing that we're really looking at is this reorg because of the span of control aspect. Because even outside of Medicaid, what is our general fund? It's around 600 million on Medicaid. I still then have almost 500 million general fund for the rest of the programs. And this is, so that's one of those things that everybody need to realize is the scope and span of health and social services is massive. So even without, you take Medicaid out, the rest of the general fund spend, it's still the second biggest department. Or third, I guess that would make it the third biggest behind transportation and corrections. And so that's one of the things we really need to do is get this kind of span of control, because when you look at the overall size of the department, 14 state departments are my budget right now is the size of 11 state departments, the court system, the governor's office, and the legislature combined. I have as many positions as 7 other departments combined. Most of my divisions are bigger than most other departments. My commissioner's office and IT staff are bigger than most other departments. And so these are things that when you look at span of control really does this, because when you're then talking about scope of dollars, right, that massive Medicaid budget spend, managerial aspects in doing things even 1 or 2% better from an administrative side can lead to savings, making sure that we're actually capturing as much as possible. And that's where you can gain efficiencies. We saw this with our Division of Public Assistance by implementing new leadership and really investing in technology there. We went our backlog from 15,000 down to 500. And we really responded, and we actually put forward a budget savings of $9 million. And it was, the whole goal was actually to provide better services and response time to Alaskans. And so by kind of consolidating this span of control and actually putting our managerial stuff there, we look toward, because one of the lessons we learned from that FY19 budget was also, even though something may have the word optional next to it, as in optional benefits of dental assistance, we were the first state to try to remove that. And then as we went through this process with CMS, they said, "Ooh, actually, in fact, under the Affordable Care Act, it's not optional. Even though it says optional, it's really not optional. You need to provide this as part of the enhanced benefit package. So if you don't do it under this guise of a defined program, you're going to pay it anyways." And so what ended up happening was, if we had gone through with really getting rid of the adult preventative dental program, we were still going to have to provide dental services with no caps, with no program definitions. And so it's little things like that we were all kind of learning together throughout that process. And so we, realized that, a lot of this stuff is here. So how do we make it run as best as possible? And we also fully aware that while we have this certain budget situation we're looking at, and everything looks at how do you get Medicaid out, that there are the economic benefits of the federal dollars brought in. We have the most sophisticated tribal health system in the United States, bar none. It's amazing when you go to small villages and you see the level of equipment they have for telehealth items, that we are bringing health to rural Alaska. And that is something that is a very valuable aspect. And we continue to work with our tribal partners on how we can actually increase our reclaiming items through our coordinated care agreements. And so when we look at this, from my perspective, when we're putting together our Medicaid budgets and other items, it's the administrative efficiencies from the state side. How do we remove burden from our providers? How do we make sure that are there innovation aspects that we can work on together in order to really deliver services in a very regional specific way? And those are the things that we're looking at.
So I would also like to add just a touch to that if I could. And first off, I'd say if you're in Juneau, we have lost power here, or a great section of us have. And if my computer suddenly shuts off because it runs out of battery, I apologize, but we don't have any power in Douglas or North Juneau. One of the things I look at when it comes to the department is just the diversity of mission set. For me, it's not just the size. I mean, obviously, if you go to the state of New York, their Department of Health is larger than ours in personnel and budget. So it's not just the number of people that you're dealing with and the amount of money. It's the mission set. And let me try to explain it that way. Much of what the department does falls into these two categories, right? One is direct care. We have nurses at API, which provide direct care to patients 24/7. We have personnel at DJJ that provide direct care to people 24/7. We have a hard stance, a building. That's where people are. The rest of the department is not that way. I mean, for the vast majority of work that we do, it's 8 to 4:30 cubicle work, regulation, oversight, administration. We process claims. We make sure that facilities are licensed and that providers are licensed or enrolled within Medicaid. All of those types of things that run Medicaid. And the two don't get along all the time. I mean, if you look at the federal statutes, which the department runs under, Medicaid runs under this statute over here, and has a very onerous burden of responsibility back to the federal government. Medicaid is a contract between the state and the federal government, and that's how it needs to be viewed in our responsibility towards it, in their responsibility towards us. But the rest of the service line answers to that administrative and regulatory oversight, which causes a lot of confusion and difficulty. And I'll just give you a real quick example. API is a hospital. It's licensed as a hospital. It's accredited by the Joint Commission. But the survey teams from the federal government that come in if there's a complaint or if there's a problem, or even just the annual surveys that happen because there's not a problem, those are personnel of HCS, which are within our division, within our department. So you have one division, healthcare services, that has some sort of administrative responsibility and oversight of the other division within the same department. And then at the same time, HCS is also running the funding that provides for API. And so there's this tension and conflict that occur within the department over those topics. And I don't want to blow that out of proportion and make it seem like it's a horrible deal. I'm just saying that there are more than one mission set within the department. And sometimes taking care of a patient at a bedside and making sure that healthcare is exactly the way it should be and that patient gets the best they need is not the same thing as processing a claim in a cubicle in a different building. And I think it's reasonable to see that if you are expending energy in both directions at once, all it does is wear you out. And that's what's happened in the commissioner's office. And frankly, in the history of the department, is there's such a diversity of mission set that we spend all of our time running after fires and attempting to put them out when the emergency occurs. And we have less and less time to devote to honest, open conversation with our partners like Commonwealth or other groups that have good ideas about how we can bend curve on cost, because we're responding to emergency. So I think in the grand scheme of things, having the two departments would allow the Medicaid program to focus on being proactive and having those ongoing conversations and partnerships that it really takes to go to the next level. And by next level, I mean, if you look at other states and how they're handling their Medicaid programs, the ones that are successful have the best relationships between the state program and their provider groups, and they run things kind of together, meaning they make joint decisions that make sense. And I'll do one example of that. You know, in the state of New York, they do the spending cap, which is in the PCG report. The spending cap is a joint effort between the provider groups and the department that says, look, we're going to set a number and we're going to maintain that number. We are going to only allow 1% of healthcare growth this year in this sector, in hospital sector, for example. How are we going to get there? Then all the hospitals sit down with the department and they say, what about this idea? What about this idea? And they hash something out. And they as a group come to the decision of how they're going to do that. And everybody has buy-in. In an emergency situation, if they can't come to an agreement, or if the cost is too rampant or whatever, the statute allows the commissioner the authority to just make the decision and say, well, you guys are deadlocked. I'm going to make the decision. We're going to go with plan A instead of plan B. But there's still buy-in and there's still that conversation. And really, I think if you're going to grapple a $3.4 billion monster to the ground, you're going to have that teamwork to make that happen. And I really am pushing for that separation in the department, just because of the mission sets and that ability to be proactive. So that's kind of my take on it. And I'll hand it back to you.
So Juanetta, do you have questions that you want to share with the Commissioner and Deputy Commissioner?
Indeed, we do. Thank you, Ralph. Let's start with a question from Marge Stone King, who's online with us this morning. She's with AARP. She's asking about, within the scope of Medicaid, home and community-based services and telehealth are cost savers and the modalities that elders, seniors are interested in, most want. And so in that respect, what are you looking at in terms of expanding or continuing after the health emergency in these areas for Medicaid beneficiaries?
Well, thank you for that, Marge. You always have thoughtful questions. Absolutely continuing with our home community-based provider side. This is something that we are always kind of looking at for innovation items. A lot of our meetings and outreach with both the care coordinators and the direct service providers over the last couple of weeks, and we also have a listening session on this coming Friday, is to talk about the enhanced FMAP for this population. and what's the best way to go through this. Because one of the things we've noticed throughout this is wages is a very big sticking point in workforce. And so how do we actually put forward items and do rate evaluations to keep this program sustainable, because we know how valuable it is to Alaskans. And so there are always costs to that, but there's also business cases to prove the other way. So we're trying to work together to put this information together. As far as the telehealth side, Al, do you want to speak to that on some of the items we're looking at?
Sure. And also I think it goes back to a question that was asked earlier as well, which is, what is the guidance from CMS? That was a general question that was voiced earlier. And this is where it comes down to really where the rubber meets the road. There are a number of topics out there, a number of service lines that were provided flexibility underneath the public health emergency and in the setting that we're currently in dealing with the pandemic. One of the greatest changes or areas of flexibility was around that telehealth. And I think it was a really good decision by the federal government to do that. It has had a tremendous impact. In particular, in the state of Alaska, obviously, we have huge distances to travel, and many states don't take that into account at all because they have a road system that they can deliver. Here, we obviously don't have that, and so that issue of telehealth and travel is extremely important. However, I would say the guidance from the feds on whether or not those flexibilities are going to continue, or which I would rather put it, which one of those flexibilities are going to become more permanent, has been slow in coming. So when we have the conversation about what are you going to do with telehealth after the public health emergency, their response has been, yeah, what are you going to do with that? And so I know that the federal government has been having those conversations because I'm on the national calls all the time. And so CMS is having those conversations internally around what they're going to do long-term with those flexibilities. And so we have two things going on at once. One, we're waiting patiently sometimes on CMS to provide those more definitive answers. Yay, the power's back. To provide those more definitive answers as to a direction and a way ahead. When the 1135 waiver, if you know what I'm talking about, and the Appendix K, which are the two guiding documents which give us a waiver of authority during a public health emergency. When those two expire, the federal government's going to come back with guidance and tell us what they're continuing in lieu of that or what they're not going to continue. So that's one thing. The other thing we have going on is that internal discussion within the state as to which things we want to continue and move forward. If we want to make the flexibilities around telehealth more permanent, it will likely take a state plan amendment in maybe even a waiver or just some change in the service line that we're doing. And so, yes, we are in conversation with CMS and our provider groups and internally around those topics. But it is a slow conversation and sometimes frustrating. I wish in a lot of ways that there was an easy button, that you had on your desk when you're in the middle of one of those conversations, you could just reach out and whap that and everything would be better. But the reality is, even on the ARPA money, it comes out in little chunks. And by little, I mean, $40 million at a time. And the guidance on that little packet of money isn't real clear. They say, hey, here's some money for this. And then about 4 weeks later, you'll get a little bit more guidance on what you can use it on. And about 4 weeks later, you get, well, then you also have to track it this way. And so there's this evolution of information on different little programs that are going on within ARPA. And I don't mean to deride that because I think it's an important function that CMS is doing. I would say that the slow movement of information is difficult at times, and it's really hard to manage. So in this conversation we're having with the Home and Community-Based Services group, we're meeting with that group probably more than any other group that we have as a constituency group. One, because they have immense need, and two, because the 6.2% FMAP match that came up as an offer is out there, but without a whole lot of guidance from CMS. And so that's the problem, is we're having the conversation about what needs to be done and then what can be done. And then we're waiting on guidance from CMS as well. So it it's a conversation that moves forwards in surges. We'll get information and we'll move forward a couple of steps, and then we wait, we move forward a couple of steps, and that's kind of where we're at. But we're very engaged with that conversation.
Great, thank you. Emily Ice is online with us today, and Emily's question, I think, is largely addressed by your previous answer, but she's also asking about the permanency of telemedicine post-pandemic emergency health. And but she specifically calls out behavioral health services. Any additional comments on telemedicine for behavioral health services?
Commissioner, if you don't mind, can I jump on that one? So my background is behavioral health, and I got to tell you, the flexibilities for telehealth have hit behavioral health in a positive way, probably more than any other field that I've seen in healthcare. There's been a huge uptick in people actually showing up for appointments when they're made, medication management, and the outcomes based on their therapy because of that. I think it's because it's easy, right? So in the past, if you had 2 kids and you had to go to see your counselor and have a group session, you had to find childcare, you had to get across town or wherever you're at to go to that counselor, and then get back and deal with all of that chaos. With telehealth and the way it currently is, all you do is walk over to your kitchen table, flip on the camera, and you're good. And I think that that's really been a tremendous boon for behavioral health. I know I was at a conference not too long ago about opioids in particular, the substance abuse treatment providers were talking about the rate of people actually showing up for appointments for substance abuse counseling had increased. And I know that's a huge issue around substance abuse treatment, if people actually showing up for the appointments that they make. So I think there's been a positive impact. I would say that there's a lot of different pieces. Mechanically, when you're talking about telehealth, there's a lot of different pieces. And so when you ask about, are we going to continue telehealth flexibilities? Well, yes and no. I mean, there's 1,000 different things that you can do with it. We may pick 50 of them and move forward with that, or 5 of them and move forward with that. But it's not a one-size-fits-all response. In the state of Alaska, we'll probably parrot something like we currently do. We're looking at the amount of travel, in particular, out of bush communities or out of communities that have less accessibility to healthcare than say Anchorage, and the interplay with telehealth. That is, as travel has gone down, telehealth has gone up, and we see that as a good thing. So we're looking at which aspects of telehealth we should make more permanent, and we're talking to our provider groups about that option.
Great, thank you. Well, I can provide some personal testimony with a dad with cognitive decline and prostate cancer right in the middle of this pandemic. Telemedicine has been a real lifesaver for us to keep him on track, so we appreciate that service. Dave Rees is online with us, and he's asking how the reforms or reorganization policies that you've referenced this morning, how will they work in terms of responding to Alaska's high incidence of suicides, alcohol abuse, and domestic violence? And he adds here, for clarification, I think what he's looking for is how state policies versus federal or Medicaid policies are going to jive. How do we get the flexibility that we need to address the circumstances here in Alaska?
No, I can appreciate that. We have an alcohol issue in Alaska, and we don't put nearly enough money towards prevention side on that. And when you look at a lot of our opioid issues and through the OSMAP team, a lot of the individuals who get into the opioid and some of those other drugs started with alcohol. And how do we actually reach those individuals and get further upstream? That's what we've looked at. I know that we have actually put forward requests. The Attorney General what year are we in now? I can't remember. We put forward a request of other attorney generals actually asking SAMHSA if opioid response dollars could actually be used for items like alcohol, because that's the one thing we absolutely have to continue to pursue. We have to get better at that across the state. And with the reorganization aspect, it just helps make it a focus, because kind of the way this is right now is public health has always been its kind of own little island. Within public health is a very big agency that's got 600 and some employees. It's got many, many little little sections that kind of operate, and some of them will get CDC grants, some of them get SAMHSA grants, and they operate just kind of in their own. They have this very big amount of an institutional inertia. And Al's worked in the department a long time. He can attest to the fact that you've got that group huddled in their corner, just doing their thing. And they've always found a way to have either general funds or federal grant dollars in order to do the work, and haven't necessarily had to work on the connections with Medicaid and throughout the rest of the program to share, right, on both the chronic prevention side, as well as, hey, we've got Medicaid eligible populations that aren't being served. And so that is something that we want to absolutely make sure we can connect. And this is just going to require time and effort. And that's where the reorganization can come into play on that. The other aspect on that is we have a hole in our system when it comes to treatment. We actually have, and Al can correct me on this, we received a waiver from the IMD exclusion for SUD treatment to have more than 16 beds. And we have yet to have Al, do we have a facility that has built that yet or taken advantage?
We do.
We do. But there's
I
more
won't
there.
single them out, but we do.
Okay. But we could probably have more investment towards that side when it comes to the treatment aspect. And so these are things that we'd like to get help quicker. This is where Crisis Now can actually help with these items as well, because it's just making sure people are getting the help they need at the quickest possible, at the lowest level of care. And that's not to say we don't want to provide higher care, but it's just a matter of scale, right? There's only so many psychiatrists, and sometimes people just simply need a trained ear to listen to you, and sometimes that's a peer. And there's peer programs that are available under the 1115, which we really need to get stood up as well. So this is something that we really want to put an effort on to make sure public health is working across the board with Medicaid, with behavioral health, and the OSMAP program, that we are moving upstream.
One thing I'd like to add just real quick, and I don't want to talk long on it, but I want to clarify this misconception that some people have. You know, what the commissioner just talked about was a careful balance of funding sources. Some's from SAMHSA, you know, some's from other sources, FNS, food stamps, you know, those things are a mix of funding sources, but Medicaid only pays for medically necessity. You know, medical necessity is the driving factor for Medicaid. So when you come to prevention, that's a problem, because unless you can prove medical necessity, Medicaid's not going to pay for it. Now, there are some you know, tests and things like that's not true. So for instance, you can test expert testing under Medicaid, and that's you know, although that's just a test, Medicaid still pays for it. But ongoing treatment, Medicaid has a hard time with prevention as a service line aside from treatment, because prevention doesn't always fall under the medical necessity hat. So I bring that up because a lot of people point towards Medicaid and they say, well, why aren't we doing more preventative work? And my answer to that is because Medicaid's not designed for preventative work. It does do a little bit of preventative work. So I'm not saying that it's exclusive. I'm just saying that it's not designed for it. Medicaid is designed to pay for medical necessity. So we have to find the funding for preventative work in other places, and we do. But it's just an important distinction to make when we're having the conversation.
Okay, thank you. The PCG report anticipates a super waiver with 4 different areas and subsidiary goals. And I guess what I would ask you is, change management is, you know, there's a particular art to it. And if the super waiver is pursued and received, how do you anticipate that kind of large scale change management being operationalized within the department?
I'll just do kind of briefly. I mean, with this has been something that is, it's not new. We've been talking about this for a long time now. And so we're in, you know, year 2.5 of the process of the public engagement throughout some of these items, getting what comes forward. So as with anything that we have got to move forward, one of the things that's, you know, I don't come from healthcare or this field. I come from industry. I just happen to have a public health degree, so I can speak this language to a lot of stuff. And so I have seen, coming forward, just what are the questions, what are the concerns? And I'm not married to any system as it exists at all. I just want to see it run better for Alaskans. One thing is I've had a lot of conversations with a lot of different groups on subjects, and what I've seen throughout is a lot of people will say, yes, we've got to change, we've got to move forward. And then the department or division puts something forward and then people go, you can't change anything. And so that's something we really all together have to wrap our heads around. And so I applaud Commonwealth North, which is why I think, Winetta, you got an immediate response. We said, hell yeah, I'll come talk to you, because this is going to take all of us together saying we have got to change and move forward. We have got to change and move forward, because this system, if it continues at this pace, will absolutely cripple our entire economy. Because while a good healthcare system is actually a very important thing, I'm sure there's a lot of business folks and economists that are part of Commonwealth North will agree that a thriving healthcare economy is not actually a healthy economy, because usually it is subsidized greatly, like in Alaska, by government dollars, where there is an overall threshold and then there's an unnecessary pressure put on the private sector. And so we do have to find a balance. We have to find a way to take care of our vulnerable populations, to keep them healthy, to work towards prevention, while at the same time having stable systems that actually recruit and attract talent that the private sector and private sector insurance can take advantage of. And so it is this dance that we absolutely have to do together. And I hope at this point in time that with conversations like this, everybody recognizes we need to make some changes and we have got to move forward together on this. And so when it comes to these items, a lot of these things take a long time. The 1115 waiver, I'm going to get the date wrong, but I think it was initially kicked off in like 2015, wasn't it, Al? And it took years to come together to not only get approved.
The order was Senate Bill 74. So yeah, it was even before that.
Yeah. And then to put into place. And so these large waivers take a very long time, and it takes a lot of coaxing, and hopefully we can figure out what are the required glide paths and how do we get these things in place together.
One thing I'm a little curious about, and I want to clarify, because I know this is a group of influential people, so I want to make sure we get our terms right. But I heard you use the term super waiver, which I'm a little leery of. It's not. I don't think it's in that term's not in the PCG report, and we're not thinking about writing one giant waiver to cover all this issue. The PCG report is a series of choices, plug and play demonstration projects and pilots that in programs that could reduce the cost of care while improving accessibility to that care. So I want to make sure that we're not talking about just a super waiver. The other thing I want to go back to is what the commissioner's talking about is just this ongoing dialogue has to happen. The dialogue around healthcare has to happen. Aside from, blame, and aside from fear, and aside from anger over accessibility or cost or whatever, we as a people must have a dialogue around what it is that's driving our cost. And I'll go back to something the commissioner said just a minute ago. Our biggest problem in the state is still alcohol. I mean, I know we get funding for opioid recovery and whatnot, but the impact of alcohol on our healthcare system and our economic system is immense. And until we get a handle around that, we're going to continue to struggle with the availability of treatment and the impact of alcohol in our families' lives. And I don't mean to sound preachy, but Medicaid's not going to solve that problem. I can't just throw treatment dollars at alcohol and make that go away. So we rely on community groups, statewide groups like Commonwealth North to actually drive that conversation and dialogue and say, we as a people need to view our communities and our relationship with alcohol in a different way. And we need to start turning that curve as well. One of the things I was super jealous of with the commissioner is he got to go to Iceland at the beginning of his term as commissioner to see what they've done to revamp their system of healthcare around the topic of substance abuse. And it's remarkable. And I would challenge all of you to take a look at their healthcare system, in particular, how they handle alcohol, because 20 years ago, They had a huge issue with alcohol over there. I would dare say bigger than the state of Alaska. And they have been able to turn that around in 20 years. Our problem is, and I'll point at me too, but our problem is all we do is talk about right now when it comes to money. And I'll go back to that. All we do is talk about this legislative session and this budget that we need to pass. The only way you can get a handle on alcohol is talk about generational stuff. We're talking about years worth of planning. We've got to have that dialogue at some point, or we're just chasing the dollar.
Youth engagement is key.
Absolutely key. My generation is already lost when it comes to this. Sorry, guys.
Thank you for that. We have Brenda Moore online with us today, and she's asking about the administration's position on the Allpayer claims database. Is that an action that is favored by the administration, or is there some other alternative that you're considering?
Absolutely. Governor Dunleavy put it forward last year. Director Winghire of the Division of Insurance sat there and testified on that. We work to make connections with individuals. And so we are big proponents of this, but could not get any kind of movement in the legislature on it, which is a very disappointing aspect. This is something that would absolutely help and is just one piece of it in order to move things forward. But because one thing we do have is, data. What we don't have is info. We need a way to actually collect things and do decision support services in order to really action what is the data and the info that we do have. And this would have been a tool for that. And just very disappointed that we could not get the traction in the legislature throughout. This was something that we really put a really honest effort in over 2 years in order to move forward.
Tom Shard is on with us, and he's asking about, there's some big plans and some significant needs that we've discussed this morning. But particularly in the fourth year of an administration, what's realistic to tackle this year, hopefully coming out of the pandemic, being in the fourth year of this first term, and what do you see moving into the next 4 years, if that's a reality?
I appreciate that, Tom. From my perspective, I'm still pushing on the reorganization. This is something that my staff fully believe in. It came from them. I think this is the long-term future of the department in order to run, because we are one of the last remaining mega agencies. And so I have been doing my outreach meeting once or twice a week with different groups over the last entire year, sharing information and talking about this till everyone is assuaged with their concerns. If the governor chooses to reintroduce that, that's on his prerogative, but I'm continuing to push that because I do see that as how we make Alaska a little bit better, and how do we actually engage in these conversations going ahead. As far as other legislative items, this is kind of what part of the internal dialogue is right now. What items are worthwhile? Because it's not just the fourth year of administration for him, it's also an election year with redistricting aspects. And so it's going to be interesting when we go into January about, I imagine they may be quick to do their work more so than usual in order to get out the door and campaign, because they'll have different populations they'll need to campaign for if districts are redrawn. So this is going to be an interesting aspect. I'm not entirely sure how this is going to play out, but this is why you see us here today, early this morning, joining it, because we're continuing on these efforts, want to continue providing this service, and we're trying to continually make health and social services run better for Alaskans.
Anything else? Okay. Emily Becker's with us this morning, referencing back to the situation in Iceland. She's saying they have universal health care. Do you think that has made a difference with regard to their efforts, and particularly, I'm imagining with the earlier discussion about alcohol?
When someone can correct me if they've gone, I know the Matsu Health Foundation has sponsored a couple different groups to go over there. My experience in going over there, that actually didn't come up very much. It was actually direct investment in the youth engagement programs is what the change was. That was one of the big items that they really came together, is they had to actually give kids something else to do. And so they created these after-school programs. Now they have the benefit over there of having exceedingly cheap energy through their geothermal. And so they were able to build massive facilities because if you didn't know this, it's the same latitude as Anchorage. And that's one of those things is like, they're just as cold as we are, just as long of winters, but you got to give them something to do. And so they actually built these large facilities and they use the geothermal to heat their pools. And so they've got exceptional swim teams and athletic facilities and these really invested youth engagement programs where school buses pick kids up, bring them immediately into facilities. And that's where they spend a number of hours each day until their parents are available. And so that was what they did. And it wasn't so much on the universal healthcare side.
Yeah, I would say the only place I see the universal healthcare issue coming up. First off, not only is it on the same latitude as Anchorage, they got about the same population, right? So they have a pretty finite population group. So it's kind of like a little, a test tube, so to speak. They can isolate their population because they already are. Universal healthcare helps, you would think, in the terms of cost. However, they pay for it in different ways. I mean, their tax rates are pretty high. So one way or the other, their healthcare gets paid for. What I would say around the term of universal is, again, I'll go back to the term of evolution of healthcare systems. The US healthcare system is changing. And I think we need to recognize that, whether or not we like it or hate it. The reality is it is changing, and it's changed over time, and it will continue to change, and we cannot expect it to stay the same. And in regards to that, a lot of the payment that they're moving towards is more towards payment for bundled services rather than an individual service. Why? Because it's cheaper for everybody. That's why. So it's a lot easier to write one bill than it is to write 25. That's just case in point. In the state of Alaska, we have that problem in spades, meaning not only do we have individual bills, but we have individual systems for each type of service. So you have primary care, then you have mental health care, then you have behavioral health care or substance abuse care. And all of those different kinds of services are basically different tiers. I mean, if you're in substance abuse treatment in the state of Alaska, you realize you don't necessarily get paid in the same way or in the same with the same amount as a primary care doc does. I mean, we're all aware of that. So if you bundled, like in a home health situation or health home situation, if you bundled that substance abuse treatment with the primary care doc that's going on with the care of that person, then it becomes cheaper to do, and you don't have to run redundant systems. I don't know how many providers in the state of Alaska are running 2 EHRs or even 3 EHRs and doing double or even triple data entry just to maintain their healthcare systems and their billing capacity. That's ridiculous. That all has to stop. If we're going to ratchet down cost, we're going to have to start paying for things in different ways. So that conversation around universal healthcare, a little scary for people because managed care, health authority, all that kind of stuff is difficult for people to swallow. But there's ways for paying for different things in different ways without embracing, the big scary socialistic medicine. I would point out the 1115 waiver for behavioral health does exactly that. We bundled payments. There are 2 or 3 different ways you can bill for bundled payments of services under the 1115, which are cheaper for the provider to bill, and the service still is provided to the patient. So just a real quick example of cost, and you all probably have many more than I do.
Great, thank you. Just FYI, page 43 on the PCG report references super waivers.
Thank you. I'm going to have to take him to task for that because I don't want to do a super waiver.
Right. Well, and I your point is very well taken, is that the language is very important, and we need to understand and use common language that everybody agrees to. Commissioner, I think you probably anticipate this question. Alex Hills is online with us today, and he's asking about the data breach. And if you could maybe provide an update on that and let us know if there's been any known ID theft.
First, thank you for finding that, and I see where it says super waiver. I did a search and I couldn't find it, and then it's in an image. Yeah, we have to fix that out.
Yeah, I just found it.
So the question on the data breach. I hate, there's two C words that I hate right now. It's cyber attack and COVID, and they're just the worst, and they've totally dominated this year. So with the cyber attack, it was a very, very sophisticated group. It was an advanced persistent threat. And it was not only us, it was a couple of other states that have actually gone through that as well. We've taken a very prudent process. And so where were groups that were servers that were able to be fully stood up and be hardened, we have been able to. One of those was the vital statistics server, so under Havers. So this is your birth certificates, death certificates. Those were able to get back online rather quickly. Other groups which have a lot more connections, right? So vital statistics is really an internal working server. People send their information in, we work on this. But you've got other things like our NAB system. This is our Alaska background check system for childcare, foster care, healthcare providers. When this information has a lot of different connections, when we go through a security analysis, this was something that we were not comfortable standing up fully to the public. And so it stood up internally. And so we're working on what's called whitelisting, which actually means we are putting information together in doing direct kind of confined pipes, so to speak. I'm paraphrasing stuff from my IT folks because this is what they do. But as opposed to a flowing river, we're just building pipes into some large areas or provider groups so they have a means of safely communicating information back and forth. It's taken a while to stand back up, but I can say that one of the other states that was hit stood up items too quickly, and they were hit again by that group. And so we have taken that to heart, and we're trying to make sure that we are doing a very good job of protecting Alaskans' information. The governor has authorized, and we have put together contracts to bring in outside help for the remediation. So we've got our security contractors, but we've got individuals from different groups that are coming in to help focus solely on the remediation side. This is the complete rebuilding of the servers through backup data in order to get back up online through the hardening. And so we are continuing to process through this. This is a tedious process that I'm so sorry that it's taking this long. Really, I have stretched any authorities I possibly have to the absolute limits when it comes to the background check side. Feel like Oprah, you're going to be waived, and across the board. And I'm trying to do this because we really want and understand the impetus to get people hired, that you've got somebody recruited, you've got somebody on the hook, and the time frame it takes to get provisional licenses or other things is enough time for them to go take a higher paying job, probably at a fast food restaurant. And so we want to make sure that we are doing everything possible. So our time frame has gotten a little bit better. We did have a really, really rough go of it. When was that, Al? That was like in late August, early September, that we had half of my background check staff got COVID and had to leave the office. And so they were all out. And so we did have some really long delays where it was taking 4 weeks for complete applications. But I believe we're back down to our regulatory time frame. But this is something we're still working on. Really, this is as much efforts as possible. So much so that I will be asking for supplementals to pay for overtime costs for this extra contract staff in order to move these items forward. The governor has authorized us to move this because we know it's critical to make sure these services are provided to Alaska, because it's not just the background check unit, it's the rest of them. It's the GEM system when it comes to grants and contracts, where my grants and contracts team have to then do everything and get reports out by hand, which is tedious when you think about the hundreds and hundreds of contract grantees that we have. So much so that I have had a lot of grants and contract staff say, I'm done. Thank you. See you later. Because the overall stress and the effort was just too much, and that I've had staff walk out. And that's one thing that it's hard to say because we're all hurting so much. And I can't really say this publicly, but the pressure on the state employees throughout this thing, I have had so much staff just not even with other jobs lined up. It's just more say, I can't take it. It's been 20 months. and I'm out. And you can't blame them. And we just say best of luck, and come back if you get your rest.
Well, nothing like spicing up your administration with a global pandemic and a cyber attack. So,
This has been a comedy of errors. I had the earthquake on
Oh,
day
yeah.
-3. I had CMS and the Joint Commission about to shut down API. We were really, really that close. And then everything else that kind of gets stacked up. This is it's not boring.
Absolutely. Sandra Heffern is online with us, and she's asking, with regard to, some Alaska learning from other states with regard to their reform efforts, as many of them are much further along than Alaska is. And she's asking if you've given any consideration to exploring some of those pilots. I know not only just the pilots, their evaluations, any information coming from those efforts. And I know the PCG report does reference, I think, 3 or 4 peer states to look at some of their reforms efforts. So where are we with that?
Absolutely. Always trying to look to see what's been done before us, because it's difficult being the first one to bring something forward to CMS. It takes a very, very long time to prove it, and so you want some other models to look at. One thing that, as we look at it in Alaska, and most people involved in healthcare understand, we are a fee-for-service state, and because we don't have a robust managed care. And so one of the reasons for that is because we do have a large tribal population and a sophisticated tribal health system. And so this is one of the things that PCG actually talks about as a possibility for us to have conversations about, a tribal health managed care aspect, because we want to make sure that we respect the work that has been done by our tribal health partners, that this population gets taken care of, and we can move forward. And so little things like that are just limitations that truly do make Alaska unique, having so many federally recognized tribes with a robust tribal health system in place. You want to make sure that those investments aren't in vain. But we're absolutely looking to. The nice thing is, with a lot of the flexibility, so to speak, for the department under SB 74 from 2016, we have demonstration projects that we are evaluating with other groups. We want to see some kind of localized items and selections, and so we are moving forward on a couple items. Some of them aren't ready for primetime announcement, but this is something we are absolutely going to advance. So one of the difficult things is that we had the bummer of a global pandemic, which put everything on hold. One of the things that we got with the enhanced FMAP from CMS of the 6.2% tied to the federal public health emergency was that you cannot do anything towards your eligibility system. And with that, while we're still scrambling to make sure that we took advantage of as many flexibilities from the 1135 and Appendix K waivers, also took all of our attention away from any innovation projects. Because a lot of innovation projects, you have to do defined population groups and try to move people in and out. And it just wasn't a possibility. So we have lost almost 2 full years because of that. But we still want to kind of continue on down that path and set up the department for future success, hopefully, so the Department of Health in the future can really be raring to go to put innovative items in place.
Great, thank you. Well, it's about coming up on 9:15. I'm going to go back to Ralph and see if you have any maybe closing questions, or if you'd like to close us out for the session.
Well, I want to thank, excuse me. I very much want to thank Commissioner Crum and Deputy Commissioner Wall for joining us today. I think we should note Deputy Commissioner Wall's adaptability here in adjusting to the power outage down there in Juneau and sticking with us. We really appreciate that resilience of your system. So thanks very much for joining us. I know it's been a real opportunity to hear directly from you folks about what is going on. Let me close by telling our audience some upcoming events for this program. We have 2 sessions scheduled in December about healthcare reform. One of them is actually Heather Carpenter, who is the healthcare policy advisor to Commissioner Crum. She was engaged in SB 74, a bill that was passed in 2016. It's been referenced 2 or 3 times today. There were a lot of initiatives in that bill, and we've asked Heather Carpenter to talk about what's been going on with SB 74, what we've perhaps learned from SB 74. And then on December 9th, we have arranged for Deputy Regional Administrator from CMS, Daryl Means, to come in and talk about federal initiatives and reforms. So perhaps we'll have an opportunity to ask Daryl Means what we can expect from the federal government. So those are 2 upcoming programs in December. I'd also point out for those of you who are have long connections with Commonwealth North to note that the Hickel Awards and the Egan Awards are scheduled for next Thursday evening. That's November 4th. And we certainly urge you to join us. These are going to be an online program. So please look at that information. So there'll be upcoming sessions that those of you who have joined us today will get announcements from Juanetta. I think Juanetta is going to put her email in the chat box. If you have comments that you'd like to share with Juanetta about these programs, suggestions perhaps for upcoming programs, Juanetta will be very pleased to take those. So with that, Commissioner Crum, Deputy Commissioner Wall, again, I want to thank you very much for joining us today. We really appreciate you taking your time out. So
thank you. Thank you so much. I'd like to say actually, the latest draft of PCG actually does not have the super waiver word in that. So we did that was caught in advance. And I am just, if you don't know, Heather Carpenter was out on maternity leave. And she's like, this is her 2nd week back. We are so grateful to have her back, and I hope you enjoy the conversation with her because she's incredibly knowledgeable about this. Thank you so much for the invite.
And Al, did you have something else you wanted to say?
Actually, Commissioner already caught it. He's way ahead of me. I would just say that the link that was posted from PCG is from 2019. That's great. And that was the report at that time. There will be one coming out, and we'll make sure Commonwealth North gets it. But the super waiver concept was taken out of it, and we moved to a couple of demonstration projects. I think a total of 6, but thank you.
Okay. All right. Great. Thank you so much. Yes, I have included information about the Hickel and Egan Awards, and as well as my email address in the chat. And just coincidentally, one of our Egan Award honorees this year is Commissioner Crum, along with Governor Dunleavy and Dr. Zink. And so we look forward to acknowledging them on Thursday with the Egan Award. So please join us for that event if you can. And with that, I think we're done. So thanks to everybody. Thanks to everybody online for joining us. And do contact me if you have any questions. The recording will be made available to everybody who's registered by tomorrow afternoon.
Thank you.
Thank you.